Hello everyone, my name is Dr. Jacques Balaila from the Department of Obstetrics and Gynecology at the University of Montreal. I'm honored to present to you today the Montreal criteria for the ethical feasibility of uterine transplantation, an ethical framework for the execution of the uterine transplant in humans. I would like to first apologize for not being able to be there in person to give this talk today, and I want to thank you also for assisting to this presentation. I hope you enjoy it. I would like to state that I have no conflict of interest to declare. As you know, the uterine transplant is proposed as the cure for uterine factor infertility, the congenital or acquired absence of the uterus. Whereas the most common cause of acquired uterine factor infertility is hysterectomy for malignant disease, the most common cause of congenital uterine factor infertility is MRKH syndrome and other Mullerian anomalies. The prevalence of UFI is age-dependent, and it is estimated in the literature to be anywhere between 3 to 5% of all causes of infertility. The figure from the CDC in the United States shown here provides a distribution of the different infertility diagnoses amongst patients undergoing assisted reproduction. We can see that uterine factor infertility is the sole cause 1.3% of the time, whereas in 10.5% of cases, the female alone will have multiple factors. Some of the ethical tensions in the uterine transplantation debate stem from the fact that other alternatives exist for women with uterine factor infertility in order to have a child. These alternatives are gestational surrogacy and adoption. While the debate over whether adoption is in fact a true alternative to uterine transplantation falls outside the scope of this presentation, we can say a few words about gestational surrogacy since it would at least provide a woman with genetically related offspring. If we look at the map showcased here, we can see that the majority of countries are gray. That means that they either have uncertain or unregulated surrogacy laws. On the other hand, countries in green, which are large in size but few in number, are the only ones which allow either commercial surrogacy, altruistic surrogacy, or a combination of both. Perhaps most striking are the countries in dark red, where surrogacy is banned. In particular, the majority of Western Europe and Scandinavia figure within this list. Even in countries where surrogacy is either acceptable or unregulated, religious concerns may prohibit couples from undergoing surrogacy. Therefore, it is not clear that gestational surrogacy is a truly viable alternative to uterine transplantation. And it is this reality about the state of gestational surrogacy in the world that prompted in part the study and the development of uterine transplants. The world of transplantation has seen major advances in the last century. Though some efforts to transplant a uterus had been attempted in the second half of the 20th century, these were largely overshadowed by the development and implementation of in vitro fertilization. Hence, the first modern effort to transplant a human uterus came in the year 2000 by a team in Saudi Arabia who lacked any formal research background to perform the procedure. With regards to the non-clinical and ethical considerations, it was said that, after thorough evaluation, the recipient was found to be eligible. Indeed, no specific ethical considerations were made in the original report. Following a graft failure of that initial experience, no further attempts were carried out in Saudi Arabia. Instead, the team in Sweden, led by Professor Brandstrom, undertook a series of sequential animal experiments for over a decade. It was only after rigorous testing was undertaken that human trials were attempted. Following success in animal species closely related to the human, the Swedish team made medical history when they welcomed into the world the first baby born off a transplanted uterus in 2014. Still, what about ethics? What role did biomedical ethics play in advancing the cause of uterine transplants? Had ethics even been considered at all? The truth is, no ethical framework existed at the time, and no one appeared to have considered the ethical implications that uterine transplants had. In 2008, the International Federation of Gynecology and Obstetrics released a report on uterine transplantation from its Committee for the Ethical Aspects of Human Reproduction and Women's Health. The report concluded with four major statements. Number one, uterine transplants should only occur after significant and adequate research in appropriately large animal models has taken place. Number two, the lengths to which some women will go to experience uterine transplantation can lead to a conflict of interest and may put pressure on researchers to move prematurely from the experimental stage to the human application at the clinical level. Number three, it is unethical to remove a uterus for transplantation from a young woman who did not complete having the desired number of children or whose uterus has any malformation. But perhaps more importantly is point number four. The authors of this report conclude that given the lack of data on safety and the known hazards to live donors, the procedure is considered ethically inappropriate. We must make mention and take note that this report was published in October 2008. However, by 2010, it had become clear that the success of uterine transplants in large animal models had been shown beyond a reasonable doubt, and human trials were planned in Turkey and Sweden. Now more than ever, an ethical framework which would help bridge the animal experiments to the human application was necessary. It was this gap between the animal experiment and the human application that led to the development of the Montreal criteria for the ethical feasibility of uterine transplantation. These criteria were published in 2012, and they are primarily a principlistic analysis of applied bioethics using the available literature published up until that time. The Montreal criteria were inspired by Moore's criteria for surgical innovation, and as mentioned, were intended as a bridge between animal and human research. In addition, the Montreal criteria is inherently neutral, and it is conditional on procedural success. Ever since its publication, they have been recognized at the international level as a framework to ensure the uterine transplant's ethical execution. Moore's criteria for surgical innovation are a set of criteria deemed to be required for the instauration of new surgical procedures. The first criterion is known as laboratory background, which implies that the research foundation for the procedure needs to be sound before the human application of that novel surgical procedure. The second criterion is field strength, which requires the adequate synthesis of knowledge and expertise from all fields related to the procedure. And finally, the third criterion is known as institutional stability. This criteria addresses the overall level of expertise in the institution in which the procedure is performed and includes all clinical services, as well as how well they function in an interdisciplinary manner and the quality of the support services that are available to patients undergoing a new procedure. When we look at the case of uterine transplantation and apply a principlistic analysis as described by Bichat and Childress, we find that the principle of non-maleficence argues against the application of uterine transplants. Why does the principle of non-maleficence argue against the case of uterine transplants? Because the principle requires persons to refrain from causing others harm. As we know, uterine transplantations involve bodily and potential psychological harm to the recipients and the donors. It is therefore the reason why the principle of non-maleficence encourages extensive research of the potential risks to the donor, the recipient, and the fetus before the widespread application of the procedure. In addition, it also reminds us that we need to promote stringent medical and psychological evaluation of uterine transplant candidates prior to approval. These notions are particularly important in the current experimental phase of uterine transplants. On the other hand, the principle of autonomy argues in favor of uterine transplants. Primarily, it asserts the rights of persons to make their own choices and mandates that others respect these choices. We know that the principle of autonomy gives rise to the right to self-determination, including in the dominion of one's body. Finally, the principle of autonomy supports uterine transplants in the context of proper informed consent, which respects the donor and the recipient's right to govern their own bodies and reproductive potential. The two remaining principles, namely those of beneficence and justice, are equivocal regarding uterine transplants. For example, the principle of beneficence, which encourages persons to do good for others, depends on the particular instance of uterine transplantation, specific donor, recipient, as well as the specific healthcare team. The principle of justice, which promotes the equality of persons, the right to equal access to opportunities, and the right to be given one's due, requires that the participants of clinical trials be part of the population that will benefit from the research. It also recommends that uterine transplants be offered to all appropriate candidates if it is found to be safe and effective. Once again, we always have to make a distinction between the experimental phase, where the uterine transplant is currently, and the potential for its future widespread applicability all over the world. Let us now delve into specifics and explore the Montreal criteria for the ethical feasibility of uterine transplantation. Before we look at specifics, it is important to understand that the Montreal criteria presupposes that the uterine transplant needs to be shown to be safe and successful before its widespread application. If and when its safety and success have been shown, the Montreal criteria then stipulates a set of requirements on behalf of the recipient, the donor, and the healthcare team performing the procedure. Let us now look at the specific criteria that must be met by the recipient in order for the procedure to be considered ethical, as per the Montreal criteria. The recipient must be a genetic female of reproductive age with no medical contraindications to transplantation. We'll explore this issue further in a moment, but the requirement that the recipient be both a genetic female of reproductive age and with no medical contraindications to transplantation stem directly from Moore's criteria that there be adequate laboratory background before implementing the procedure. As all animal research on uterine transplant was done on genetic females able to undergo transplantation, it follows that human recipients ought to share those same characteristics. If and when the procedure is researched on males, then this criterion will no longer apply. Second, the recipient must have documented congenital or acquired uterine factor infertility, which has failed all current gold standard and conservative therapy. Because the uterine transplant is a major undertaking with considerable risks, the principle of non-maleficence dictates that it should only take place if all other treatments to preserve or restore fertility have been tried and failed before. Third, the recipient has either a personal or legal contraindication to surrogacy and adoption, or seeks the uterine transplant only as a measure to experience gestation, with an understanding of the limitations provided by the uterine transplant in this respect. Fourth, the recipient has not had her decision to undergo uterine transplantation deemed as irrational by expert psychological evaluation. This criteria makes reference to Moore's criteria of field strength, which ensure that an interdisciplinary effort be put in place for all aspects of novel surgical procedures. Fifth, the recipient does not exhibit frank unsuitability for motherhood. We believe that just like for adoption, an evaluation of suitability for parenthood is key before undertaking a major endeavor to reproduce, such as the uterine transplant. And finally, the recipient is responsible enough to consent, informed enough to make a responsible decision, and not under coercion. While social stigmas for childless couples have been described, it is imperative that the patient be under no coercion to undergo the procedure. Informed consent and bilateral changes with the treating team is fundamental before undergoing the transplant. With regards to the donor, it is required that she be a female of reproductive age with no medical contraindications to donation. Second, it is required that she has repeatedly attested to her conclusion of parity, or she has signed an advance directive for postmortem organ donation. We know from the research that has been done that both living donors and cadaveric donors are potential donors for uterine transplants. As per the report from FIGO in 2008, it is imperative that the donor has repeatedly attested to her conclusion of parity. In other words, that she has attested on numerous occasions that she no longer wants to have any children of her own before she donates her uterus. Third, it is imperative that the donor has a uterus without any damage or disease. Once again, this seeks to ensure that the chances of pregnancy in the recipient are maximized. And lastly, just like for the recipient, it is required that the donor be responsible enough to consent, informed enough to make a responsible decision, and not under coercion. In particular, this becomes an important issue in places where organ donation may be compensated. And finally, the Montreal criteria also sets a number of conditions that must be met by the healthcare team performing the uterine transplant if such transplant is to be considered ethical. First, it is imperative that the healthcare team be part of an institution that meets Moore's third criteria as it pertains to institutional stability. As we had seen before, this implies that all of the tools are in place, that there be an interdisciplinary effort, and that both donor and recipient can safely undergo the procedure. Second, the healthcare team must have provided adequate informed consent to both parties regarding the risks, the potential sequelae, as well as the chances of success and failure to the best of their knowledge. It is also important that the healthcare team not have any conflict of interest independently or with either party. And finally, as with all other organ donations in most countries, it is imperative that the healthcare team preserve anonymity if the donor or the recipient do not explicitly waive that right. Despite the necessity and the appeal of ethical frameworks for novel procedures, such as the Montreal criteria, some criticism has been raised in the literature. Amongst the most important concerns figure the following 2 points. First, are the Montreal criteria discriminatory towards transgender male to female individuals when it requires that the recipient be a genetic female? Second, how can we apply the Montreal criteria in pronatalistic societies? Regarding the transgender individuals that would like to undergo a uterine transplant to have a pregnancy, we must first realize that no research has been done on the male species. And we have stipulated in the Montreal criteria that the risk of the transplant is only worth taking if it is carried out for the purposes of procreation. Now, the idea of having a pregnancy in a man does raise some concerns. However,
Unlike what people tend to suggest, the concern does not stem from hormonal or delivery issues. In other words, we can give a man the necessary hormones until the placenta kicks in to sustain gestation, and we could theoretically perform a cesarean section for delivery in a man. However, the main concern actually stems from the embryo transfer, because this particular individual will lack a cervix through which we can transfer the embryo. There are techniques today that transfer the embryo through the uterine muscle, but the success rate for those is quite low comparative to regular IVF, and this kind of research has not been carried out in men.
Nevertheless, in 2013, we updated the Montreal criteria and published it in Fertility and Sterility. We address in that paper this particular issue, and we conclude that there does not seem to be a prima facie ethical reason to reject the idea of performing uterine transplant on a male or trans patient. Because a male or trans patient wishing to gestate a child does not have a lesser claim to that desire than their female counterparts. After all, the principle of autonomy is not sex-specific. However, to reiterate, because the research has been done only on females, according to Moore's criteria, it would be then unethical, because of the lack of laboratory background, to perform the operation on males. Once we overcome the anatomical hurdles and the technical hurdles in transferring an embryo into males, there will be no ethical reason not to research the uterine transplant in males. The second criticism of the Montreal criteria comes from a pair of articles which apply the Montreal criteria to a particular setting in the Middle East where there are low-income and pronatalistic societies. We'll look at the case of Pakistan, as explored by Mumtaz and colleagues in 2012, published in Clinical Research and Bioethics, and we'll look at the Lebanese context, which is published by Altawil and Arawi in Developing World Bioethics in 2015. Mumtaz describes the Pakistani context. It is described as being a patriarchal, hierarchical, and pronatalistic society where women have little decision-making power or rights. They talk about the potential for violence. In addition, they discuss the reality that most transplant units are not accredited and do not adhere to international standards of safety and quality. Therefore, in their paper, they conclude that the Montreal criteria may not capture either the unique context of women globally, nor context of structural violence which can be exacerbated by the emergent biotechnologies such as the uterine transplant. Looking at the description where women are often coerced, where there is violence or bioviolence in forcing women to have children, it is precisely for these reasons that the Pakistani context violates the minimal ethical requirements for the recipients, as well as for the donors. When they say that most transplant units are not accredited and do not adhere by international standards of safety, then there are violations to the Montreal criteria with regards to the healthcare team. Therefore, it is for these reasons that under its current circumstances, the Montreal criteria finds the uterine transplant ethically indefensible in societies such as these, where coercion is the norm and where transplant units are not accredited and do not meet standards of safety and quality. Similarly, Altawil and colleagues in 2012 provide us with a criticism of the Montreal criteria in the Lebanese context with a Middle Eastern perspective. In their paper, they argue that infertility is not just an obstacle to be tackled by the husband and the wife, but rather, in many cases in Lebanon, extended family members, for example, both mothers-in-law, are involved, and the decision to undergo fertility treatments is tackled as a group effort. For this reason, it may be misleading to state that the Montreal criteria do not apply to these contexts. In fact, it is precisely in such contexts where group decisions may violate reproductive autonomy that an ethical framework such as the Montreal criteria is necessary. While this particular framework may come into conflict with the Lebanese context, it is the Lebanese context that may need to change before the uterine transplant may be ethically carried out in that country or in that context. The authors acknowledge that regardless of cultural acceptance, one can argue that societal and familial coercion into undergoing a surgical procedure falls into the realm of violation of human rights and reproductive autonomy. It is precisely the reproductive autonomy and the lack of coercion in undergoing a major procedure such as the uterine transplant that the Montreal criteria tries to protect. In conclusion, the Montreal criteria for the ethical feasibility of uterine transplantation came about as a way to bridge the gap between animal and human research as the uterine transplant was introduced in humans. They set specific proposed conditions for donors, recipients, and the healthcare team performed the operation. They were developed using bioethical principlism as a function of the available literature and the theoretical considerations surrounding transplants. They have set an international standard for the ethical execution of the procedure, although they have no regulatory or enforcing body, as these are not absolute, but rather may serve as a stepping stone for ethical issues in individual cases of uterine transplantation. So that's it. Thank you very much. I hope that you've enjoyed this presentation and that it led you to think about some of the ethical issues that surround the uterine transplant and how the Montreal criteria can serve to resolve them.